I'm going to turn over to Dr. Mélanie Ann Smithman. She's currently a postdoctoral researcher at the Upstream Lab. It's been a huge privilege to work with her. She has a strong focus on primary care access quality improvement. She's actually a quality improvement coach at the Université de Sherbrooke in Quebec. And she has a really strong passion around primary care innovations. And she's part of the Quebec College of Family Physicians, which many of you will know has been doing some fantastic work around innovations and how do we implement them. So I'm going to turn it over to her.
Thank you, Andrew, for that very eloquent introduction. No pressure. So this morning we thought we would take a little bit of time just to set up what we're talking about. And I don't want to go into too much of what the problem is, because if you're here, you already know there's a problem in primary care. But we're kind of just going to go through 10 facets of the crisis together. Does this work? Yes. All right. So you know there's a crisis in primary care. Every week, every month, we see new headlines that look like this. Across the country, we see reports of family doctor shortages, people who don't have access to care, and all the consequences that that brings for the rest of our healthcare system. And so I was looking at these headlines and I started to roll back time to see how far we could go in finding similar headlines. And we can go, I stopped in 1960. Yeah, so we have a crisis. And maybe it is worse because we have gone through COVID. Maybe the cracks in our foundation are showing a little bit more and there's a lot more pressure. But we see similar headlines going back to 1960. That was even before family medicine. Article in 1966 talks about the general practitioner shortage and the fact that people couldn't get access to care. 1970, urgent need for medical teams in Ontario. I mean, it's been a while. So the question is why? Why are we in a perpetual state of crisis in primary care? Perhaps it's not really a crisis. Maybe this is a crisis by design. So 10 facets of the primary care crisis. Essentially, when people are talking about the crisis, they're talking about slightly different things. So often we talk about the fact that people don't have, for example, a family doctor, and other people are talking about a slightly different part. So we said, well, what are people talking about when they talk about the crisis? And we realized there's different facets to this, and it really is a wicked problem. So if you're not familiar with the concept, it's essentially the same thing as, climate change or these sort of really big, multifaceted problems. And every time we try to solve one aspect of the problem without considering the others, we're kind of pulling on this twine. It's like a big knot of yarn. And if you pull at it too hard or in the wrong direction, you're actually creating new problems or new knots in your yarn if you're not considering all the different aspects. So that's why we thought we would take a few minutes just to go through the different aspects of the crisis. So what I did is I went back 20 years and I looked at editorial text, policy documents, kind of anything that people had published and that talked about why we're in a crisis. It could be opinion, it could be research-based, and I synthesized this into the 10 things I'm going to talk about now. Well, the first that comes to mind, obviously, I think, which maybe is, front of mind for everybody right now, is the workforce shortage. What's interesting, though, is there are different aspects to the workforce shortage that people talk about. The first is capacity. Obviously, we feel like we don't have enough, for example, family doctors to go around. There is reduced capacity within our existing workforce. So there's burnout. We have an aging workforce or early retirement. So we're losing people earlier. There's fewer hours, fewer patients, fewer clinics. So people are working less than they did before. So even with an absolute same number or increasing number of professionals, we're actually producing less access. We have a decline in the comprehensiveness of family medicine and primary care that is being offered. So people are specializing a little bit more on certain things. And there is a growing private sector. And that's something that came a lot with COVID and teleconsultation, and the fact that now primary care professionals can kind of double dip in the private sector as well as the public sector, which wasn't possible before. So we're losing people giving part-time hours to these private sector companies. The second aspect is the allocation. So of course, have persistent challenges with recruitment, retention of these professionals. There's uneven geographic distribution, so we have pockets where we just don't have anybody to serve the population. We have issues with licensure and the fact that we can't transpose our licensure across Canada. And then there's kind of this hole in literature or in what people are saying, and it's very focused on family physicians, but then we keep saying we need teams. So a lot of the workforce planning has been around family physicians. We haven't really done whole workforce planning where we're thinking about all these different roles and how they can provide care and counting that in how we're planning our workforce. We also don't really train our allied health roles to practice in primary care specifically. I mean, nurses is a really good example. They come into primary care from other sectors often and are not really ready to practice in primary care. So they're not at the full scope of what they could be. So this is the longest one. The 9 others will be much quicker. Systemic inequities in access. I mean, the prevalence of unattached patients. 1 in 5 Canadians doesn't have a family doctor. 1 in 3 where I live in the East End of Montreal. So that's huge. We have ingrained systemic discrimination, and Andrew likes to say it's not by accident that some people are excluded from care. There are systemic and structural reasons why we're excluding certain groups from care, and we need to think about those. There are rural-urban disparities that are enormous. The people who need the care most aren't getting it. And really, there isn't much diversity of representation in who is making decisions, so we're not seeing any improvements in this. Number 3, our system is complex and fragmented. We have a patchwork of models in primary care that have evolved through history. I mean, Ontario's alphabet soup is a very good example of that. Coming from Quebec, it took me a little while to figure out all the different models that we have here. It's a navigation nightmare for patients. The front door of healthcare keeps changing, and we are not really informing them of where they can get into the system. There's a rise of retail walk-in clinics. I mean, Walmart has just invested massively in Canada to open these small, quick access clinics with low continuity. There's very poor integration of mental health and social services, and that really hinders coordination, continuity of care, which we know are key to good primary care. Number 4, inadequate funding and payment. These numbers might have changed, but about 5% across Canada maybe goes to primary care of our funding, whereas that's double in other countries in some places. The incentives to family physicians are often misaligned with what we're trying to produce, and we often see unintended consequences of the remuneration models that we adopt. We inject unsustainable funds into our system over and over. We have these funds coming into primary care that are not sustained, and we see kind of emergence of a pilot project and good idea, and then it doesn't get sustained over time. And we have a predominance of the small business model in primary care, which makes it quite difficult to actually get the funds to patient care. So we lose a lot in the structure and in the small business model where everybody's trying to manage their own thing. Number 5, outdated infrastructure and technology. I mean, the fax machine. Enough said. We also have a bunch of incompatible softwares. We don't really plan for the future. We've seen AI coming for years, and we're still grappling at how we might integrate it into care. We have digital inequities, which are translating to patients. They can't access teleconsultations, for example, and we're excluding patients from their health records. We are wasting a ton of energy and time and resources. Administrative burden is front of mind right now for a lot of people. Some estimates say that family physicians spend between 10 and 20 hours a week doing administrative burden. If just one of those hours was converted to patient care, everybody would have a family doctor across Canada, just one of those 20 hours. We have low value care. Our friends from Choosing Wisely will say maybe about 30% of the care that we're delivering is really not necessary and even harmful. That's a third of the care. That's huge. We're duplicating services over and over. 7, governance disconnect. Primary care is not part of our health systems. That's huge. Policymakers are making kind of remote policy decisions about primary care that isn't really formally integrated into our health system. There's a huge influence of lobbying groups, including physicians, who come and shape the policy decisions that are being made. There really isn't much community and patient representation in the government's level, and there isn't much social accountability or accountability at all in terms of the results. Ad hoc reform, implementation, and evaluation. Andre Picard wrote this summer in an article, Canada doesn't have a healthcare crisis, it has an implementation crisis. We have the solutions, we just haven't gotten them on the ground. We also love to restructure. So we keep restructuring. When in doubt, we restructure, and it makes everybody kind of a little bit loopy, trying to figure out who's in charge. We also have a short-sighted, crisis-driven solution. So often we are trying to solve really immediate crisis, and that's important, but we also need that kind of longer-term vision, and creating that capacity to address long-term solutions is a really big challenge. 9, escalating demand. The demand for care has changed. Yes, this is related to the aging population, but not only. Demand has increased across all age groups, especially for younger demographics. There has been a shift in the culture for on-demand care. People are using more care. There's higher burden of comorbidities. There's the pressure that have come from the pandemic, and there's kind of ever expanding treatments and guidelines and diagnostics that primary care keeps taking on. And finally, we focus on downstream disease, and this comes to the idea of the upstream solutions that Andrew was talking about earlier, but really we've forgotten this whole part of the primary care vision that was set out by the WHO and other kind of reports of tackling the social determinants of health, or the root causes of what is making people sick. So that's the 10 facets. In tackling this problem in the next few days, we need to keep all 10 in mind, because if we target just one, we risk making the others worse. The last question I want to leave you with is, who benefits from this crisis? We've been in a crisis for 60 some years. That's not by accident. There are people who benefit, and it might not be in the traditional sense. Maybe it's people who stand to lose out if we change our system. Here are some of my ideas of who might benefit or lose out. Private care, pharmaceuticals, the consulting firms who tell us how to change our policy, insurance companies, governments and politicians who may lose out if they have to make hard decisions about what we prioritize. Certain health professionals who might be happy about the business that they're getting. And while there is rampant burnout, there are certain health professionals that might be benefiting, maybe in secondary or tertiary care. There are also people who are getting care, and they're quite happy to be getting the care that they're getting right now, and they are privileged to get that care. So just keep that in mind in terms of the power dynamics of how we make this change in the next few days as we're thinking about solutions. Thank you very much.
Thanks so much, Mélanie Ann, and that was a fantastic, and you covered a huge amount of ground.